So conflict of interest are listed here, and none of them are of importance for this presentation. This is the outline of the talk. I will give you a very brief introduction. I only made one slide. I knew that there would be a lot, you know, as a nice introduction this morning already. And then this talk will be a little bit unusual. Usually I like to talk about like 1 or 2 topics. So this is where I really decided to touch base on 6 different topics, which I think are all very important for lobular breast cancer detection and diagnosis, prognostic predictive markers, models. I expand a bit more on unique pathway activation, growth factor receptor signaling, immune response, metastasis. And then I will try to summarize. So I'm going to start off my presentation to lay really the foundation for some of the things I talk about with a study we recently finished, which is a really large retrospective cohort analysis of patients from 3 different institutions, from UPMC, Cleveland Clinic, Case Western, and Ohio State. So we were able to collect data from more than 33,000 patients, and this includes 3,600 patients with ILC from those institutions. And I will not go into detail about the study now. Neil Carlton, a student in the lab, will talk about this tomorrow. But just very briefly, again, setting the stage, what we learned doing this is, we learned quite a few things, but what's important for the presentation today, and this was mentioned earlier by Otto already, that in our data set also, we see more late recurrences in patients with ILC, which is a red line here. This is disease-free survival, and the same for overall survival. Similar, when we look at stage, red is ILC, blue is IDC. We see patients with ILC have fewer early stage and more stage 3, stage 4 disease. We do think in part this is biology, and in part this is late detection of disease. I am absolutely not an expert in imaging, but I thought this is important to mention this here, that the challenge of late detection of disease has been recognized. Imaging is a problem. It was, I think Eleanor mentioned this earlier in her presentation, and I think there are now a couple of studies ongoing just to use better tracers for imaging. There are at least 2 clinical studies ongoing, and I want to show you 2 figures from 2 publications here. This is from Brenda Kurland, where she compared imaging with either a tracer, which measures basically estrogen receptor, functional estrogen receptor, and compares this to imaging, traditional imaging with FDG, PET imaging, which looks at metabolism of glucose. And you can see in the same patient that the FES is much more active, and this is a side-by-side comparison from Gary Ulana, where again the FES imaging is much more active. Again, there's actually one study specifically ongoing in patients with ILC, and I think we'll can expect a lot more from this over the next few years, given that the lobular tumors is such an estrogen-responsive disease, as you heard earlier this morning. Transitioning now to diagnosis of the disease and the finding of the disease, we have heard a really brilliant talk this morning from Matthias Krisken. One of the studies he has published over the last few years is shown here, and I think it nicely represents the tradition of diagnosing ILC from early in the 40s, just as a breast cancer rising in the lobules, but then transition to saying, okay, this looks different, it has a special growth pattern, and now defining it as a morphomolecular entity, which is characterized not only by different morphology, but also by different molecular makeup. And I think, to me, it is personally, it's again my personal opinion, to me it is quite surprising that we know that ecdysone is the pathognomic feature of lobular breast cancer, and that ecdysone isn't more frequently used for the diagnosis of lobular breast cancer. And with respect to this, and this was actually just accepted, this is from Maxime in Christine's lab, and many others in the room actually who did this. This is a survey to look at use of ecditorin in the diagnosis of the disease, and they had almost 150 respondents to the survey from 34 countries. And the result is that half the pathologists use ecditorin, so they perform immunohistochemistry for ILC diagnosis. You know, there's really a lack of concordance which antibody is used, and only 4% perform DNA sequencing for ecditorin. So I think there are more studies ongoing, and I think we hear more about this controversy over the next few years. In addition to defining, you know, what antibody is used and in which setting this is done, I think the simple question of inter-observer agreement in diagnosis, just using histomorphology is very, very important. This is a paper, and I think Matthias showed this briefly this morning, but I think it's important enough to go over this again, that in this study, 35 pathologists were recruited to do diagnosis of ductal, lobular, and mixed cases. And this is results from using only H&E, and this is results from using H&E and ecditorin. And these are basically the different pathologists reading this, and these are the different samples. And you can see that adding ecditorin, it becomes tighter. There is more agreement among the pathologists. So the pairwise inter-observer agreement was moderate when only H&E was used, but substantial when ecditorin was added to the H&E. And it was specifically challenging when there were ecditorin positive lobulars harboring CDH1 missense mutation, ecditorin negative lobular with tubular elements, focal picaditorin expression, and ILCs with trabecular growth. And the conclusion from this was that subtyping of breast cancer as ILC achieves almost perfect agreement with a predefined reference standard if assessment is supported by ecditorin IHC. So again, I think we will hear more about this in the next few years. I think there is a lot of debate, but yeah, hopefully there'll be additional studies supporting this. I think in addition to the ongoing discussion about whether to use ecditorin or not, I think there will be more and more introduction of AI into diagnosis. This was an exciting presentation from George Rice Philo's group at San Antonio last year, where at least for me, I think it was the first time to see the use of AI for diagnosis of ILC. Very briefly, what the group did, this is actually with Page AI, that they applied a classifier system which was trained on 40,000 whole slide images to identify early lesions as well as invasive disease. They then generated a mathematical algorithm and then used this for cross-validation to predict either the presence or absence of ecditorin. And the results are shown here on the right, and you can see that the sensitivity and specificity of this algorithm to predict biallelic ecditorin mutation and globular phenotype was very high. Again, these are the early studies, and there's no doubt that we'll hear more about this. Another state-of-the-art technology, and actually I just saw already a poster upstairs on this, is the use of digital spatial profiling, or DSP. I'm sure that it will take quite a while to get this into the clinic, but I think for research purposes and understanding lobular tumors, this is very important. I'm not sure if anybody can see any of the colors in the back, but trust me. So basically, this is done by Osama, a graduate student in the lab, and the samples were stained. And actually, I should say, we specifically think, we look at mixed ductal lobular tumors where we think the spatial analysis is especially important. So the samples were stained with ecditorin, pan-cytokeratin, stained for DNA, and vimentin. And then he looked at, this is done with nanostring, the spatially sequencing of ductal and lobular region. If you could see this, then this is all red and this is all blue. Basically the ductal and the lobular cells after the sequencing, after the RNA sequencing, the first thing Osama did was actually comparing the RNA level for EKTRN. And so again, there are 3 cases of mixed disease, and for the first 2, the absence of EKTRN in the lobula was reflected in the RNA-seq of these cells. And in the last case, actually, that was not the case. In the last case, we still saw RNA expression, but at the protein level, the EKTRN protein was lost. This is this case. The analysis, Osama is still working on the analysis, but one thing I already want to share. So he now looked at PAM50 calling at these individual small region of interest, at these ROIs. And this is actually just as an example, this first case here, and in this first case, he has 5 regions in each for the ductal and the lobular. And you can see, okay, the PAM50 score, when it's red, it's a high likelihood of that specific PAM50 score. And basically the ductal region, the ductal cells in this mixed tumor are all basal, of basal origin. It's a basal tumor, and the lobular is a luminal A tumor. So maybe coming back to what I think Matthias talked earlier, that in some of these cases, you have these collision tumors, and we think this is a good example here, where you have a basal IDC, a ductal tumor, and a luminal ILC as a collision tumor. So we do think that this technology is going to be very powerful to understand lobular breast tumors. So to transition to prognostic markers and prediction, we have heard a lot about this already. There are quite a large number of papers, and this is really nice. This was actually really nice summarized by Christine in her keynote address last year. And you heard about this earlier this morning from Otto and Darren already. But the consensus is that there are very few high-risk ILC as defined by Oncotype DX. A number of studies published. We did the same in the Great Lakes Breast Cancer Consortium, which I mentioned on the first slide. So when we take the original cutoffs, we have exactly 2% of cases of ILC which have a high risk, Oncotype DX risk score, compared to 11 in the ductal tumors. When we use a TAILOR-X cutoff, we have 6.9 in the high risk score and 16.9. So just again amplifying that we have that assay identifies very few patients with ILC4 with high risk, despite quite a significant number of patients recurring, especially with late recurrence. So more assays are needed. Darren gave you a really nice presentation this morning on the OncoMaster assay, on these 3 prognostic, these master gene regulators, but others have been published. This is actually a study spearheaded by Otto Metzger on the BCI, and this was published almost 2 years, last year, where the group showed that the breast cancer index was able to significantly stratify patients with ILC into risk of overall 10-year, early and late distant recurrence. The data is shown here on the right. So on the y-axis, basically, you see distant recurrence, and this is either in the low, intermediate, or in the high risk prediction. In addition, that assay reclassified a meaningful number of clinically low-risk tumors as high genomic risk and clinically high-risk tumors as low genomic risk, concluding that BCI is an independent prognostic factor for ILC. And another assay, and without going into detail, I think we heard about this actually at both prior lobular conferences. We heard about this from Peter Simpson, the LOB-SEQ. Just very briefly, it's another transcriptional-based assay which can differentiate risk for low or high in all ILCs, grade 2, grade 3, ER positive, grade 2, and he actually showed that the LOB-6 is this blue line here. If you look at only grade 2 ILC, it outperforms all other assays. And it was published now a few years ago. Hopefully we hear more. Is he here? He's not here, right? Peter Simpson? No. Hopefully we hear from him soon more on the outcome and validation of this. So ILC models, I only have one slide because, you know, it was so great. I really can't show any other slides on this, right? Anyway, yeah, no, that was a great presentation, and I would like to summarize that there was really great progress on the model generation and model generation in the last few years, and but obviously, you know, we can do better. Unique pathway activation, I want to focus a little bit longer on this because I really do think that it's time to translate this into the clinic. A lot of the work was really done by, or pioneered by Patrick over the years. At first, through generation of models, in vivo models, where then cell lines were generated. This is just two examples here, showing in a paper that cytoplasmic P120 mediates anoikis resistance through ROCK-dependent processes. And when he downregulates either P120 or ROCK, you have a significantly decreased tumorogenesis in the mice. And then subsequently showing that loss of ikethirin activates growth factor receptor signaling, and you can see this here. And I think Patrick's group then also used AKT inhibitors and showed in these ILC models, when you knock down AKT signaling, you get significantly decreased growth. So these were the early studies on this. The way we got into this was actually Adrian. Adrian has studied IGF for more than 20 years, and Adrian did a screen to look for regulators, a proteomic screen, to look for regulators of IGF action. And one of the top regulators for IGF action in this screen was ikethirin. And this is how Adrian started lobular breast cancer research. Just for the records, it was not me convincing Adrian to do lobular breast cancer research, right? So honestly, so ikethirin was one of the top regulators of IGF action in the screen, and then we started to look at the effects of loss of ikethirin, or just comparing ductal and lobular models and IGF action. So this is I hope you can see this here. So this is cell lines were treated either with IGF-1 or IGF-2. These are ductal cell lines, lobular breast cancer cell lines. And when you treat the cells with IGF, you can see increased activation of phospho-IGF-1 receptor with IGF-1 and with IGF-2. Similar, when we looked at, I think this is done in TCGA, you can see, so we compare ductal and lobular tumors as a control. We have lower ikethirin, but then if you look at IGF-1 levels, IGF-2 levels, and phospho-IGF-1 receptor, you can see all of them being higher in lobular tumors compared to ductal tumors. We don't really know the mechanism. We have a couple of ideas, but I think there's lots to be done. Adrian showed these two cell line models earlier, generated by Ashu, graduate student. Actually, she just defended her thesis, but basically, Ashu generated knockdown cells of ikethirin, MCF7, and T4A7D. Again, they become hypersensitive to IGF, so phospho-IGF-1 receptor is increased, AKT signaling is increased, and what Ashu then looked was availability, or how much does the receptor bind to ligand. And the way she did this was she incubated the cells with biotin IGF, and then looked how much biotin IGF is bound to this. Again, I hope you can see this. If not, take my word for it. In the knockout cells, you have more IGF binding to receptors as compared to the control cells. So somehow, the lack of ikethirin allows the receptor to bind more ligand. We have shown this increased sensitivity to AKT inhibitors now also in organoids. Adrian talked about these organoids earlier. This is an example here where Ashu treated 2 ER-positive ILC organoids compared to a series of ER-positive ductal organoids, and she showed that there's increased sensitivity to an AKT inhibitor. This is the MK2206, which actually I showed you earlier. That's the same drug Patrick used in some of the studies, but clearly showing that the absence of ikethirin, the lack of ikethirin in these lobular cells enhances sensitivity to inhibition, to drugs targeting AKT pathways. There's quite a bit more out on activated growth factor receptors in lobular tumors. Another one is the activation of ROS1 in ILC. I think this study by Chris Lord and colleagues showed that in the absence of ficatierin, there's more ROS1 expressed, the pathway is more active, and these cells become more sensitive to drugs targeting this, and there are now 2 trials ongoing, one in the neoadjuvant and one in the adjuvant setting. We are also very excited about the HER2 mutation. This was already mentioned earlier this morning. This is in our lab, Jay Bin Lu, and Jay is there as well. Jay, you also need to raise your hand, just like Laura, there, Jay. So Jay is working on activated HER2 in lobular tumors. I just have a few slides on this. We do think this is very exciting and clearly, hopefully provides a clinical opportunity as well. So they are overall seen in approximately 4%, but they are enriched in metastatic disease. They are more common in ILC. I think these numbers are similar to what Otto showed earlier. They are more in the metastatic ILCs, up 10 to 15%, and they are specifically enriched in pleomorphic ILC. In breast cancer, the majority of the mutations are in the kinase domain here. And I think Otto already showed this slide earlier, but I think it doesn't hurt to show it again just because it is important. These are the results from the SUMMIT trial and from the MUTE-HER trial, where patients were treated with neratinib, and the green squares here are patients with lobular breast tumors. This reflects response to therapy, and you can see that the majority of responses are in patients in ILC. So there seems to be an enhanced response. So it's basically 2 things. One, you have more mutation, and second, the response seems to be enhanced. Similar in the MUTE-HER study, where neratinib was given in combination with fulvestrant, it is also shown that great anti-tumor activity, and I should say this was just recently published in Clinical Cancer Research, and lobular histology seems to be particularly responsive to this treatment. Okay, what about immune response? I think we heard a little bit this morning that in general, response to immune therapy in ER-positive disease is clearly not as strong as in triple-negative breast cancer. I'm not sure if you can read this, but maybe I can just summarize the slide. This is how we actually got into this originally. We collaborated with Ryan Hartmeyer. Ryan Hartmeyer was a student, a postdoc with us, and then he went to Foundation Medicine. And this provided us an opportunity to compare patient characteristic, genomic profiling, and I'm sure you can't read this, and this is tumor mutation burden in metastatic lesions from patients with ER-positive IDC or ILC. This is mutations enriched in ILC. Obviously, as a positive control, almost nicely, you have ficatierin. We identified an enrichment in NF1, TBX3, PI3 kinase mutation. This is not novel. Again, this just shows you, the more darker here it is. These are enrichment of mutations in the AKT pathway. But the other thing we found, and again, this is how we got into this, that tumor mutation burden was higher in patients with ILC than IDC. It's not totally black and white in the primary, but it's especially in the recurrences. Otto mentioned this earlier as well. There was an ASCO presentation from his team on this. So far, this hasn't really translated into enriched TILs in ILC tumors, either in primary or metastatic. And this is from Christine and Christos a few years ago, where they showed that overall TIL infiltration is actually lower in ILC than IDC. But this, obviously, it's just a snapshot of what's going on. So we have done a large study to characterize the immune infiltrate in comparing ER-positive ILC and ER-positive IDC. So what we have done, and this is in collaboration with an immunologist, Dario Vignali at our institution. So we have done spatial immune characterization in a large set of tumors, We have characterized immune infiltrate heterogeneity. We have used FACS analysis, and finally have done single-cell sequencing on a large number of samples, although this sample number was smaller as compared to the other approaches we have taken. And to summarize these studies is that, and this is currently under review, is that the immune microenvironment is clearly very heterogeneous, but it's dominated by T cells and macrophages. That the spatial organization identifies macrophages as the predominant cell type infiltrating tumor bed in both ER-positive IDC and ILC, but there's a significant enrichment of M2-like macrophages in ILC. The neighborhoods, and we thought that was quite interesting, the neighborhoods enriched, this is neighborhood analysis based on the spatial organization of the tumors, enriched for T cells and macrophages were actually associated with a better outcome in ER-positive IDC. We did not see that in ILC. And the tumor infiltrating macrophages are functionally and transcriptionally diverse in ER-positive IDC and ILC. This is, it's one of those, it's a huge data set, and we hope that that data set, once published, we hope that others can also mine this, and that will be a resource for additional understanding of the immune infiltrates. This obviously in the end needs to translate to clinical studies. A clinical trial is ongoing from Dr. Cook here in the Netherlands. Patients with metastatic ILC are treated with atezo with carboplatin. And the first results were recently presented. Oh, this is a gelato trial. First results have been presented. And yeah, I think the trial met the primary endpoint. The objective response rate is 19%, clinical benefit 29%. And interestingly, at least I thought that was very interesting, that 4 patients had triple negative ILC. Clearly, the rate of triple negative is quite high. I think it's quite unusual. I don't know if that was actually enriched for that subtype. And now in the Great Lakes study, I think we had less than 1% of triple negative. So, but anyway, I think this is promising. So we'll see where the field moves to. Yeah, finally, I want to talk about metastasis in ILC. This is almost 20 years ago that the team at Baylor did a comprehensive analysis of organ sites of metastasis in ILC. This is shown here. In case in the back you can't read this, they showed that metastasis to the lung is significantly decreased in patients with ILC versus increase in metastasis to the ovary and the GI tract. We used the benefit of the large healthcare system where we are. This is a UPMC McGee metastatic breast cancer database. This is done in collaboration with Peg Rosenzweig, where we have more than 1,500 women who were seen with metastatic breast cancer at UPMC. And we have prospective, fully abstracted medical records with sites of metastasis and outcome data there. And we basically observed the same what the Baylor group, Grazia Apano, had published previously, that in patients with ILC, we had significantly fewer metastases in lung and liver, and we had an increase in GI, soft tissue, and ovarian mets. We became very interested in this. Clearly I can already tell you we don't have an answer to this, but we do think that the unique metastatic site should tell us something about the biology of the disease. And I do want to mention Rachel is in the audience, and Rachel was actually instrumental. Rachel published a study here on unique metastasis, even to the eye, in patients with ILC. We went on to characterize metastasis in patients with ovarian metastasis. This is our cohort. There are 27 metastatic samples to the ovary. The majority is ER positive. This is the inner circle. We have 1 ER negative. We have approximately half of them are paired, where we have the primary tumor. Half of them are orphan mets. Half of them are ILC. 22% are mixed IDC and ILC, and 30% are ductal tumors. So I should say that's not that only ILCs can metastasize to the ovary, but you have a clearly significant enrichment. yeah, I'm very sorry that I don't think the colors really project well, but we could confirm histology in the ovarian metastasis. It's either ILC, ductal, or mixed histology. And here's a brief summary of the clinical pathological features. The demographics, the median age was relatively young at age of diagnosis. Survival, disease-free survival, the average was 77 months. We have done transcriptomics in these tumors. The majority remained luminal A tumors. We have some increase in luminal B, and then also normal. And the normal, there are 2 samples where we think maybe that has something to do with tumor cellularity. We did extensive transcriptomics and to do pathway analysis. The data is shown from the pathway analysis on the bottom here. And what I would highlight is that one of the most enriched pathway was glutamate receptor signaling. We thought that was interesting because there were 2 papers already published on glutamate receptor signaling may be enriched in endocrine-resistant lobular breast tumor. And one of the glutamate receptors is CaSR, calcium sensing receptor, and which we followed up on. And this study is actually done by Laura, PhD student. Laura, you don't need to raise your hand again. And Laura has a poster upstairs, although this is only a side project from Laura. Her main project is on the poster upstairs where she looks at the role of equiterrin in ILC. Just to briefly summarize this, that we think the calcium sensing receptor plays a role in metastasis to the ovary. The expression is significantly enhanced in metastasis, specifically in ILC. These are the red lines here. We also see increased in GI metastasis, but again, much higher in ovarian metastasis. And Laura did a number of studies on functional characterization on this, and I can just show you one here, that there is increased invasion and motility of these cells, and in the presence of calcium chloride and overexpression of CaSR, and that can be blocked with drugs which inhibit CaSR. This is the CaSR study. The ovarian met study was an analysis of a retrospective analysis where we pulled out FFPE blocks. But we also have 2 studies ongoing where we really take prospectively tissues, and this is what I'm going to end my presentation with. So one is where, and Adrian talked about this already this morning, where we really try to generate patient-derived organoids and then do drug testing in these patient-derived organoids. So this is an example. This is done by Kai, a student who also just finished, graduated, and graduated his thesis in our lab, and in collaboration with an orthopedic surgeon at UPMC, Kurt Weiss. So basically, through the collaboration with Kurt, we can get access to bone metastasis, and we can characterize the fresh bone metastasis by single-cell sequencing, and in parallel, we take part of the bone metastasis and then do drug testing on it in organoids, so grow organoids from those. This is done. This is a nice presentation, an example of where we would like to get to. This is a patient. We are really grateful to the patient for donating the tissue for this study. It was a 74-year-old woman with ER positive, PR negative, HER2 negative ILC. We had access to the tissue from the mastectomy. She was treated with various therapies. Unfortunately, the tumor recurred, and at that point, we had access to the bone metastasis. And she actually had 2 different bone metastases, which were both resected, one on the left pelvis and one on the right tibia. And we had organoids from both of those. This is just the histology from the primary and the 2 bone mets. You can see this is a H&E. The primary was a lobular tumor. Actually, you know, I don't have time to go into this, but happy to discuss this with Matthias and others. It seemed like the bone met actually went into a mixed IDC ILC, transitioned, and ER was lost in the metastatic lesions. The exome sequencing revealed druggable mutations. So these are mutations in the primary, in bone met 1 and bone met 2. and this is a mutation shared between all of them, PI3 kinase mutation, and then you can see mutation shared between both bone mets, but you can also see mutations unique to one or the other bone metastasis. When we compare this with CHASM and other databases, we identified druggable mutation, and this is PI3 kinase and the BRCA1 mutation. And we wanted then to go on to take the organoids to really test drugs targeting PI3 kinase as well as BRCA. And this is just showing you the data from the organoids. This is the organoids, so these are the two different organoids from the left and from the right bone metastasis, confirmation of lack of ectoterin, lack of ER. This is showing that the RNA sequencing from the bone metastasis correlates really high with the RNA expression from the organoid, and the same for the somatic mutation. So this is exome sequencing from this circle here is from the organoid, and you can see that the majority in both sides overlap with the mutations found in the original bone metastasis. So there's a very high degree of overlap of the mutations in the organoid compared to the lesion. And Kai also looked at the mutation signatures. He found various signatures, and again, I'm just showing this here to show that the mutational signatures overlap between the metastatic lesion with the organoid derived from the metastatic lesion. Kai also did single cell sequencing of the epithelial cells, and that's shown here. And again, I think you need to take my word for it, that the different cell types, the different epithelial cell type, the different clones we find in the organoids, it's very similar to what we see in the original bone metastasis, just confirming that these bone met-derived organoids faithfully represent the original tumor. Kai then did drug testing in these organoids. This is in vitro. He used a PI3 kinase inhibitor. He used the drug targeting BRCA1, and we saw very nice response in these organoids, so showing that they are really good models to do drug testing targeting the mutation we identified. And then finally, he also implanted the PDO into mice and treated the mice with alpelisib. And this is red as a treatment, and you can see very nice response to the drug in this in vivo model, yeah. And I want to end with, so this is just an example for really where we would like to go to, that we are very lucky, although we miss Rachel, obviously. Rachel is here. Rachel Zenkowitz with a lot of clinical studies with, but we have a lot of clinicians in the clinic where we have very close collaborations with, where we can test, where we hopefully can get to growing these organoids and testing drugs in parallel. And I want to end with, on the data slides, with the rapid autopsy. Adrian mentioned this already. This obviously is it's a very sensitive topic. It's not an easy, this is quite a difficult task. It took us many years and many investigators to set this up. I should also say that this is a logo which was designed with the 6 patient advocates who are a very close part of this team, of our rapid autopsy team, who really are, I think, instrumental in guiding us how to approach patient, how to work with the physician, again, because this is such a really complicated and sensitive topic. Yeah? So Adrian mentioned this already earlier, the autopsies which have been performed. And we are very happy that we now work with Christine, her clinical colleagues, and a team to really, hopefully, we can collaborate on this more in the future. Yeah. Just one example from this, showing the power of the rapid autopsy. This is an example, and you can't see this, but there are many metastatic lesions on this liver, and an example for the tremendous heterogeneity in one organ. Yeah, from this liver, we had like more than 20 samples, and you can see that some of the lesions in this liver were ER negative, PR negative, but others are screaming high for estrogen receptor. Yeah. So we do think that this will be extremely powerful, and we will learn a lot from the rapid autopsy program we have set up. So to summarize, Detection and diagnosis. Detection remains a problem and might contribute to worse outcome. We clearly need improved imaging. Clinical trials with new tracers are ongoing. There's a lack of standardization of diagnosis. There are ongoing efforts internationally to identify the best sensitive, reproducible, and feasible method, and inclusion of equiterran staining is an option, is discussed. I know, again, Matthias in the room is working on this, and many colleagues and within ELBCC, but also within the US, are thinking about this and working on this, and there's promise for AI. With respect to markers and prediction of response, there's a realization that tests generated based on IDC tumors might not perform the same in patients with ILC, and there's many efforts ongoing for development of ILC-specific biomarkers. I think with respect to models, I do think this is one of this area where the awareness of the problem has really led to improvement. I think we have now more models. I think one of the next steps is to really make sure the models are available for the larger research community, and they also, and I haven't talked about this at all, but it came up a few times earlier in the talks, that we need to make sure that the models represent the different lobular variants, right? I think very often we have no idea if it's classic, if it's pleomorphic, if it's alveolar, or whatever, and given that the different variants are associated with different outcome, and maybe we'll find even specific unique mutation, maybe even with different treatment response. I do think thinking more of models representing the different variants is very important. There's unique pathway activation, growth factor receptor, clearly synthetic lethality due to loss of equiterran. Again, like I tried to highlight, I think Patrick has worked a lot of this, but now over the last few years, also other groups, there is an activation of growth factor receptors, and I think it is important that this gets moved forward into clinical trials. Immune response over a low immune infiltration, potential role for macrophages. There is a subset of ILCs which have high, there's an increased rates of mutation, and there are currently studies ongoing of the tumor microenvironment, hopefully analysis of trial samples and new technologies which should provide us with really necessary data. And here is the same thing. I think the importance of histological variance in the analysis of the immune system is very important. Metastasis, late recurrence, and unique manifestation and organ sites. We need more models for dormancy and also for metastasis to organs with these serosal membranes, which I didn't get a chance to talk about this today. And there's a requirement for cfDNA tissue collection, and especially for collaboration. You have a subset of a subset. I think we can't do this as individual labs. I think I have a few minutes left. I want to end with very preliminary data from an ILC survey, which I think at least half of the people in the room here have contributed to. I want to start with thanking everyone for taking their time either in development of the survey or in responding to the survey. The survey just closed, so we just did a few analyses. I think Lee and Christine and I had a call like 2 weeks ago or so, but I think this is still ongoing, but we thought we'd just share just a few slides, just 3 more minutes, yeah. The goal of the survey was to improve management of the disease and personalized treatments through first performing a landscape analysis of current understanding, and second, identification of priority areas for collaborative research. And there are really 3 main stakeholders which were involved: the clinician, the researchers, and the patient advocate. I want to say that this was so much more work than I thought it would be, naively. So I think, I actually put the survey conception on here. I think Lee, Adrian, and myself had a few discussions early on. And then we had a few calls with others, and I remember a really long call with Mitch Dowsett, who had done a similar survey. Well, not similar, but has done a survey just to get input. How do you do this at all? And then it took like a year, or then we developed a draft, and then it took like a year where we got input from LBCA, from Laurie, from many other people, from other foundations, Dynamy, Lobular Breast Cancer UK, Lobular Ireland, ELBCC. A lot of you are in the audience who really edited the survey and had really, really critical impact. And then scientists and clinicians, right? again, people are in the audience like Patrick and Otto and Rachel and Adrian and Christine and Karen and Rita and Satoria, and I apologize to anybody who I missed out here. But the IRB was a bit of a pain. We received funding to then work with a survey facility. We did beta testing with mail stakeholder. We did final edits. And then we fielded the survey to an email list. The email list was set together by PubMed searches, ORCID, Professional Network. We sent 1,700 emails. The response rate was 39%, 95% completion rate. After that, we did additional targeted recruitment and also social media, where we had additional 1,000 responses. And again, thanks to everybody in the audience who responded. This is a response by countries. Again, you might not be able to see the colors so well, but the majority of responses were from the US, United Kingdom, Ireland, and Netherlands. Many other, we had actually representation from all continents. We had, responses from Africa and South America and everywhere. And again, I cannot thank all of you guys enough, because I think some of you I individually emailed them to reach out to your colleagues all over the world. The organization, the list of organization is like mind-boggling. It's really, really long. I mean, there are so many organizations who contributed to this. And you can see a lot of them you recognize from the US or from Europe, but you can immediately, there's the Egyptian National Breast Cancer Screening Program or the Egyptian Society for Women's Health. I mean, many organizations from all over the world participated in this, yeah. And just a few early, responses. I'm going to show you how important is it for you to know ductal versus lobular histology of breast cancer in your patients. Or actually, I should say that one of the things we are doing at the moment is really to decipher how do we analyze the data. And obviously, we want to split up the different stakeholders. The data I show here now is clinicians and researchers. But there's so much even from the advocates where I think it's a really rich resource. It will take us a while. But this is from researchers, this is from clinicians. You can see that the majority of respondents will say a lot or a great deal. How much does histology affect your treatment decision making? It switches a little bit more to moderately. And then when you go, how confidently can you describe histology and molecular differences, it switches even further. But moderately or a lot. When it goes, are there clinical trials or outcome data supporting unique treatment paradigms for ILC versus IDC? The majority would say yes. Would we find treatment guidelines specifically for lobular breast cancer be valuable for treating with patients in the future? Either yes, or the vast majority actually will say not sure, or I don't know. Have you ever powered clinical trials you are involved in to do a subset analysis? No. Would you consider powering your trials to do a subset analysis of lobular? The vast majority would say yes, or probably or definitely yes. And would you consider participating in a group consortium to conduct trials on lobular breast cancer? Probably yes, or definitely yes, which is great. The research focus area, I can't say much about. It's so much. Actually, I should say the final document which Todd sent to us was like 390 pages. So it will take a little while. Maybe we need AI to do this. And there were 6 research domains: epidemiology, risk reduction, diagnosis, therapy, treatment resistance, local therapy, and imaging. So, not surprisingly, is it adequately represented in large public available genomic data sets? No. Are there adequate models? No. Are you able to obtain lobular breast cancer tissue or blood samples? Actually, it was surprising. The majority said yes. And then again, I think, we just pulled out a few responses here, areas which were mentioned a few times. But this will take us a while to sort through this. But these were repeatedly came up: chemotherapy, efficacy and length of endocrine treatment, genetic predisposition, value of ctDNA, response to CDK4/6 inhibitors, difference in response between pre- and postmenopausal patients, HER2 mutations, the variants, cell dormancy, and metastasis. So, we think this is, I think we'll learn a lot from this. I think we really, again, I want to end with absolutely thanking everyone, especially the patient advocacy groups, which were absolutely critical in helping us with this, and I think which will be absolutely critical in us now doing the next steps, right? So what do we learn from this, and how do we now work together? We look forward to the patient advocacy session, just tomorrow morning. Colleen and Siobhan will lead this. I would like to say just one word, that Lee is not going to be here. She's not well. She says hi to everyone, so I'm very grateful that Claire has agreed to help with the session tomorrow morning instead of Lee. Yes. Yes, Lee actually prepared something she was supposed to have a video tomorrow morning. She prepared a small write-up, which I think I'll read tomorrow morning, yeah. So, my final slide, what have we learned, and does it matter? Increasing number of studies have shown that there are many similarities between IDC, but there are also significant differences, and this is the same what Otto mentioned earlier in clinical presentation, in the biology and primary metastatic disease and etiology, and there are trials ongoing to test current and novel therapeutics specifically in ILC. And you can see the number of publications on PubMed focusing on ILC have really significantly increased over the last 10 years or so, yeah. But we do need to say that currently there are no major differences in the treatment for patients with ILC versus IDC. We do need more research to really translate all of these findings into changes in clinical management and treatment. And I do think that only at the point in time when we really have differences in clinical management and treatment, that I think everybody really, the clinicians and the researcher will truly focus on ILC. I mean, I can say it as an example. We work really closely with outstanding pathologists at our institution, but when we discuss, for example, variants and go to really details, they do remind us that we need to tell them that this is important for treatment, right? Otherwise, why is that really necessary, yeah? So I think we do need more progress, and I think that, the collaborations and funding and the work with the advocacy, I think those three are the pillars for us to move forward. I'd like to thank everyone. First, I think all of this, what I presented, is done in very close collaboration with Adrian. Obviously, I think Adrian and myself, we merged our labs a few years ago, which the first year was quite rocky because we have very different styles, but now it works really well. And these are the lab members. There's a picture, great collaborations from lots of investigators in the US and outside the US, funding. Thanks to many anonymous patients for donating blood and tumor tissue. And again, I would like to thank all the clinicians, researchers, and the patients and the advocates who took time to not only help, but then also respond to the survey, and all the patient advocacy groups who we are very lucky to work with. And I would like to thank all of you for your attention.